Okay. I'm going to turn it over to Joel Saltz to kick us off.
All right, Usman, thanks. Okay, so I think this should be a really interesting meeting. We're going to have a talk about the publication process. And obviously, as projects are maturing and there is more and more work to be published, this is a really important criteria. And as Mary will describe, and many people on the call know, the N3C effort has involved a tremendous number of people cooperating and building various components of infrastructure, as well as contributing intellectual input in lots of different ways. So the whole process of attribution is really a critical one in a community like this. And I think that we're really setting new standards as a community in thinking this through and developing governance methods for it, which I think will be used a bunch of other contexts. So Mary's going to talk about this both in the specifics and big picture. And there has also been a really excellent, very exciting diabetes group that I've participated in when I've had the bandwidth, and Carolyn, Bramante, and Lauren Chan will talk about Metformin papers, data and paper overview. So so that's our plan. Next slide. Okay, so we have a remarkable enclave. I just saw we have more than 2 million patient records of COVID-19 positive patients. Fortunately, the incidence is really dropping, knock on wood. So that's good. But it's quite a comprehensive data set with 42 sites having deposited data, 55 sets having data released. And as most people know, but people who are new to this may not, these are extended windows of data, 2-3 years, so that they are natural data sets for looking both at acute and sequelae of COVID. Next slide, please. Okay, so I'm going to hand it over to Mary Saltz to talk about the Publications Committee.
Okay, let me bring up Mary's slides. All right, Mary, good to go.
Mary, I think you may be on mute.
I was, thank you. I would like to thank everybody for the opportunity to talk to the community a little bit about the N3C Publications Committee. We've gone through some growing pains and today are at a point where I think we're relatively well formed and have some things that I thought would be reasonable to share with the group and the community at large, just to give you a snapshot of where we are at the moment, where we were, and where we hope to be. Next slide, please. We are here to support team science at N3C. We work together to support quality publications, and we want to make sure that those who contribute get appropriate recognition. We also serve, as you'll see as we go through this a little bit more, as a final last check before publications leave N3C. And we certainly don't catch everything, but we try to take a look at certain specific key things, as you'll see when we go through this talk. Next slide, please. Well, as Joel said, it's a big cohort of COVID patients. I took this snapshot today from the website. There are over 2,000 members of N3C, over 2 million COVID patients. I counted 31 domain teams, 218 projects, 211 DUAs, and 88 data transfer agreements. Now, interestingly, I circulated my slides this afternoon before sending them finally to Usman, and Wendy Hernandez pointed out that there were 209 projects, which shows you that even within a data enclave, we have some numbers that don't match because it depends where you look. So I thought that was very illustrative of some of the problems that one has dealing with big data, data integrity, data veracity, all of those things that are so important to us. Next slide, please. We are a community. We're a community of funders, researchers, geneticists, patients and families, clinical research, informatics people. A lot of us are informatics people, clinical care, physicians, nurses, providers. Some of us and some of the work that's come out of the N3C, it's really interesting about drug development. And of course, we are funded by our tax dollars and the NCI. Not the N3C. Thank you. So let's look at the community overview, the committee overview. And these are guidelines that we've put together to enable the following. We want a transparent and collaborative environment where all contributions are acknowledged. We want to promote provenance and reproducibility of COVID-19 research. As all of us remember, there were some very prominent publications in the early COVID era in May or June in the Lancet that had to be withdrawn because the data just wasn't well curated and the results were not reproducible. We want to be able to share these results as quickly as possible with the caution that, of course, we want to be as possibly close to perfection as we can be, which of course we know is impossible, but we try. And we would like to clarify the attribution expectations for all artifacts from our collaborative, specifically as it relates to publications. Next. We're a volunteer group. We're all members of the N3C community. We are here to set community standards and expectations, to track productivity, to facilitate an inclusive and appropriate attribution for all publications that come from our group. We promote collaborations as a publication committee. We try to troubleshoot any authorship questions that may arise. And this group actually asked us about a month ago to please try and identify that work which we as a committee felt was particularly representative of the best coming out of N3C, so that those authors could be invited to present their work to this group. And we have added that to some of the tasks that we do. And we try to act as a final check to protect our community and to protect the authors. We look one last time at cell size. Does the DUR match the work that was done? And give it an overall sanity check. Now, not all of our reviewers are the same, as you'll see. Next slide, please. Here you can see we have a wide variety of community members with very different backgrounds. And I'd like to thank everybody. It's a great group of people. We work really well together. Someday we'll actually meet each other face to face. Right now, I think we feel like we know each other pretty well virtually, and we've been working very closely together and working pretty hard. These people are extremely dedicated to helping promote quality work coming out of N3C. And as you can see, we have a wide range of people, some of whom are on the call today. This was a last-minute presentation, so I'm not sure everybody will be able to join us. But at the end, I hope that if those that are here, those who are here, will be able to join me in answering any questions that you might have. And a real shout out to Andrea, who has been an indefatigable supporter of the committee, working day and night to do many of the administrative tasks that we need. And Christine, who brings to us her great expertise in governance. Next, please. This is just to show you that the attribution and publication principles for our committee were first put, I would say, pen to paper, but that shows you that I antedate computers, in August of last year. And over that time, we have iterated on multiple changes from that original document. And that shows you that we continue to work with you as a community to see how we can best serve N3C and support publications. Next, please. All of the things that I've shown you so far are taken from our website, but I thought it was worth going through with you a little bit of what we do and why we're doing it. And we're working to uphold accurate and traceable contributions for all N3C manuscripts. So if something goes out and there's a question about a result, we as a community can answer that question. We want to make sure that everybody who works gets credit. And this is a very interesting process. And we're still struggling with how to achieve this, to give the people who had the idea and wrote the paper and did all of the really hardest work the most credit. But then there's a group of people without whom this work could not have been done and who have made substantial intellectual contributions to the work, not just rubber stamping, but real contributions. And then there are all the rest of us who should be acknowledged, if appropriate, in any publications coming out of our community. Now, we have kind of given this a little bit of a twist and developed the idea of masthead authorships, block or consortial authors, and acknowledgement by attribution. Every contributing organization will be listed on the N3C website as seen on this slide where available. The users share their ORCID IDs during their N3C registration. That allows us to attribute to them. So that's important. Users are encouraged to list all contributors or any data resource that is ingested, as well as any report or outcome, whether they're automatically tracked within the analysis workflow or not. And we try to make sure that this workflow and the reports go upstream and downstream, and that we as a community will support the authors in appropriately acknowledging contributors. Next, please. So the first problem that we had, and this took us months, it's such a silly thing, but it took us months to hammer this out. Is a manuscript a consortial manuscript, or is it an individual DUR-based, project-based manuscript? Now, the problem, the sticking point was that at the beginning, we had a concept that everything was consortial, because after all, without the N3C consortium, how could any of the papers arise? But as we thought about that a little bit more, it made more sense to consider the papers that are about the N3C. Say if we were to write a paper on governance and the N3C, or the publication committee and our process, or our thoughts as a community about attribution of authorship, that would be about the N3C. But if a group were to say, let's look at a particular drug and see, you see how it helps COVID patients, doesn't help COVID patients. What about this drug might be similar to other drugs? That's a project-based paper. Nonetheless, it rests upon the infrastructure of the entire N3C consortium. Next, please. So you can't just go giving out authorships willy-nilly. And it is a problem in team science to begin to delineate who is and who is not an author. And it's extremely important, especially for young investigators who spend a lot of time working on a collective problem, that they get recognition for that work. It's important to their careers. It's important to everything for them. So what does it mean to be an author? Well, we support adherence to the ICMJE standards. It gets a little bit difficult when you have 100 authors, but we do not support anyone being made an author, be it a consortial or block author or a masthead author, unless they can attest to having substantially contributed to the work. Next, please. So we came up with, as a collective group, 3 levels of authorship or recognition, because they're not all authorship. One is masthead authorship, the names that are listed when the journal publishes the article. Then there's in that group that would be listed as N3C Consortium. And that is what we're considering block or consortial authorship. Then there's a third tier of recognition, which are acknowledgements. Thank you to the Publication Committee for your help and work in supporting, et cetera, et cetera. Next, please. So let's look at the 3 levels of authorship. This comes from our website, which is always a work in progress. But as you can see here, we have thought that this makes sense, that there's a first tier of authorship, a second tier of authorship, and a third tier, which is an acknowledgement. The difference between, in practical sense, text acknowledgement versus consortial collaborators is indexed in Medline. If you're indexed in Medline, then no matter who you are, someone looks you up, you get cited, you get your name recognized. And that's a very important calling card or ticket or currency in our world. And it's very important. So if you look, masthead authorship, the nature of the contribution is substantial, intellectually important contributions made directly to the manuscript. Consortial is less substantial, but still intellectually important contributions made directly to the study or manuscript, or to the knowledge artifacts used directly by the study. Note that these names may occasionally overlap with in-text acknowledgements. So we've really sort of tried to tease out what really does it mean to be an author. For example, if you write a paper on diabetes and you don't, in order to do that, you need to use the concept sets developed by the diabetes domain team and by folks like Richard Moffat, who've spent months and months and months harmonizing the data, helping people determine how do you represent, BMI? How do you represent, hemoglobin A1C? What do you have buckets? So all of those things go into defining what is diabetes, what are outcomes, and therefore we feel that those folks who were involved in developing that deserve to be authors. No, maybe not a masthead author, although some of them might, but certainly consortial authors. And then of course we must have acknowledgement of grants and the other things that are very important to be recognized. Next, please. So here we are, masthead authors, key contributors, manuscript byline, indexed in Medline. Next. Block or consortial authors. This recognizes the contribution of multiple investigators, such as domain teams or working groups. They will appear as the N3C Consortium in the masthead, but will be indexed in Medline. Next, please. The acknowledgements are things like general attributions to those who generally supported the publication, but not enough to be consistent with ICMJE guidelines or to warrant specific authorship. And then, of course, one must acknowledge the grants and the funding sources that supported the work. Next, please. So what do you have to submit to the publication committee, or what do we ask? That's a better way to put it. What do we ask that you submit? Basically everything that's going out of N3C. Abstracts, podium presentations, and press releases, however, you really just need to report to us after they've been accepted. Why? So that we can track the output and so that we can promote them. We want to promote all of our work, but we do not as a committee review or critique or do anything with this. So it's merely registering that this has happened. For full manuscripts, excuse the typo, before acceptance is when we would like to see them. When a reasonable, almost complete draft with figures and tables is ready. And this we've gone on around about many times as well, and finally decided that we really can't do anything till we actually see what the work is. We had thought originally that we would take projects early and help you through the process, but it's really not realistic. Most groups want to work on their own. They work quickly. They want to get stuff done at the last minute. They really don't want our help going through the process. It was interesting because we had thought we could make some marriages early on. You know, this group is working on this and this on that, and it's very similar, and why don't you work together? And we still do that, but not as early perhaps in the process as we would like, but it's just not practical to take work that has not been fleshed out pretty much for us to take a look at. Next, please. So where would you find, so what do we ask you to do? We ask you to go to the N3C website, and you can see here, if you can just Google it, you'll get to it by Googling it, to submit a publication intent form to the committee, either after for the non-manuscripts, and it's a little bit confusing, the terminology, because it's not really an intent form if you've already submitted and been accepted as a podium speaker on something. It's not an intent, it's a fait accompli. But this is what we have called it, and it is available, next please, here. And what is the submission process? Well, it's all on the N3C website. And if you click on it, you'll come up with something that looks like this. Next, please. And what should the authors expect from the publication intent form? A series of nested questions. I just took some screenshots asking you about, have you filed this before? What's your DUR? Is this a new submission? Do you give us permission to publish the name of the manuscript on the website? There's a whole series of questions. It should not be onerous to fill out the form. And if you have any questions about it, please do contact us. Next, please. Now, the manuscript review, I want to just take a couple of minutes on this. What are we doing and why? Well, we want to support the authors in confirming authorship and attributions. We want to verify alignment with the DUR and the finished work to make sure that we have all of the proper permissions in place, that we asked for and were granted permission to work on problem X, and that under that umbrella, this work falls. We also can offer editing on a case-by-case basis, and really comments and suggestions that vary by manuscript and by the reviewer, because as you saw, reviewers are a diverse group who don't all bring the same skill set. So someone may say, I'm concerned about the statistics. Someone else might find that the clinical applications would be perhaps something that would require more discussion. So next, please. I just go through a little bit of the process of how the manuscripts get to us and what we do. And what happens is when you finish that form, which I showed you, the submission, their N3C administrator, Andrea Volz, is automatically notified that a manuscript has been submitted. She tells me, hey, Mary, there's a manuscript. And I go to my roster of reviewers and pick 2 and tell them, please review this. What do they review it for? Well, we've asked them specifically to check cell size, make sure we're not sending out anything that could be considered PHI, make sure that it's in accordance with the DUR, look at the authorship suggested by the author, and make sure that they're being as inclusive as we think is appropriate. And we begin then a dialogue with the author about that. It's not our decision. It is a decision of the author, but we offer our suggestions and support. We can help make marriages between groups who are doing similar things. We review the data download committee authorization. That's very important because you're not supposed to publish data that they haven't approved. We kind of give it a final sanity check. And then for this group, we give it a rank, overall relative merit of the work. Is it amazing? Is it excellent, or is it good? Because everything's at least good, okay? The committee then discusses this and we vote. And then I correspond with the authors on behalf of the committee. The letters that come from me are not my opinion. It is the collective opinion of our committee after discussion and voting. And then once we get to that point and it's ready to go, the Publication Committee administration will help the authors with the paperwork needed to get block authorship, which is a lot of paperwork. Next. We don't want the authors to feel at sea or that they don't know what to do. So we are there to help. Next slide, please. So each manuscript is reviewed by the entire committee, and a quorum votes on it within 10 days of the manuscript submission. We look at the author blocks. We look at, is the DUR okay? Is it about N3C? In other words, is it a consortial or a project-based manuscript? And we give it a rank. Do we think it's, you know, amazing, excellent, or good? Next, please. So why does this take so long? People get very impatient. Well, we meet every week on a Thursday, every single week. We took the last week off, but we meet on Thursdays. The reviewers that have manuscripts by Tuesday are expected to have them ready for discussion on, sorry about that. Ready for discussion on that Thursday. And the committee votes on each submission at the weekly meeting. Next, please. We really like to have that opportunity for discussion. It has helped us a lot. We have all learned a lot, and I think we've been able to give much better feedback to the authors. But what about an emergency submission? We get a lot of those, and it's really something we try to help. We work weekends, we do asynchronous voting if we have to, we do accelerated reviews, but we really don't like them. We really don't, because it doesn't give us the opportunity to go about our normal process, which we've worked very long and hard to evaluate, to establish. And so what we won't do is approve it without at least a remote vote. Rushing this means that the author doesn't get the full benefit of our help, which I do think we can help. But of course, we're not there to hold up submissions. Next, please. So just my final words, the author's in charge. We sit in an advisory committee, advisory capacity only. The final decision rests with the authors. We are here to help and not to hinder, so we won't keep your manuscript from going out. We can only make suggestions, but if you submit to us in a timely fashion, we can help you. Next. That's all for now. And I don't know if we have time for questions. I'd leave that to Usman. But if we do, I'd be happy to help, or you can email me or whatever is appropriate. Thank you.
Yeah, I think we have time for a couple questions. What, anything out there? Okay, I don't see anything in the chat.
Okay, well, thanks everybody, and thanks to the committee members who were able to come today and listen. If you have any comments, be happy to hear them now. Otherwise, we'll go on to Carolyn, who happens to be one of our committee members. And did I put you in my list? That list was hard for me to compile, Carolyn, and I don't remember putting you on there, but Carolyn is one of our most active and most, well, not most, it's, you know, all children are equal, but Carolyn is more equal. Thank you, Carolyn.
No, I can't say that, but thanks. I have my own slides with fresh data just analyzed today. So thanks for letting me share my screen. So I'll give an overview of a manuscript that the diabetes and obesity domain team is working on. And I'll give a little background about why we started working on this, because I think the science is very interesting behind this idea of repurposed medications. At our university, biophysical engineers modeled SARS-CoV-2 and protein targets that would appear to be effective in halting the viral life cycle. And So they went on to look at, then use natural language processing to identify medications that inhibited those proteins. And you can see here, they predicted early on hydroxychloroquine would not work, remdesivir and fluvoxamine would work, and then mTOR inhibitors would work to halt the viral life cycle. So metformin has mTOR inhibiting actions. So it was interesting to think about metformin as an antiviral agent. But then doing a literature search, there actually is a history of metformin having antiviral properties. It was derived from French lilac in the early 1920s, and then used initially to improve outcomes in influenza, and then recently was studied in vitro against Zika and Hep C, and was found to have in vitro activity against those viruses. And then early on in the pandemic, the group at UCSF also found in vitro activity against SARS-CoV-2 and improved cell viability. And then in addition to potential antiviral effects, metformin has been known for a while to have sort of anti-inflammatory effects with reducing IL-6, TNF-alpha, IL-1 beta. So this is an overview of some data that predated COVID. And so then knowing about those anti-inflammatory effects and sort of modeling that on a model of COVID-19 pathophysiology, it seemed like there might be other ways by which metformin would reduce severity of COVID-19 disease, not just through stopping the viral life cycle. And metformin also has sort of antithrombotic properties as well, in action potentially with improving the endothelial function. So I got involved with a group here working with United Health Group, analyzing metformin use in one of their databases, and we found an association with reduced mortality in people who had been on metformin before being diagnosed with SARS-CoV-2. And there have been a number of other observational studies that have shown that observational data is never perfect, though. This is a view of another analysis inside our health system data early on in the pandemic. And then as all these sort of observational studies were coming out, a group in Florida did in tissue assays with lung epithelial tissue and showed some activity in most of the lung tissue. And then by the winter, I think 7 out of 7 drug predictions were correct from that initial computer modeling. And metformin has many sort of desirable attributes. It's cheap, available, safe. It's already used in pregnancy in children, and has all these other pleiotropic benefits potentially. But all this to say, it's worth, seems worth continuing to look at it because it could be used widely if found effective. So we wrote a protocol to do an analysis in the N3C database. We were going to assess whether or not there's an association between metformin prescribed before infection and reduced severity of COVID-19 in adults with diabetes with at least one outpatient visit in the 12 months before their positive SARS-CoV-2 result. And this active comparator design had not yet been done. So comparing metformin diabetes monotherapy to sulfonylurea diabetes monotherapy and to DPP-4 diabetes monotherapy. Because an issue with these metformin and diabetes observational studies is confounding by indication, and really this active comparator design is a good way to try to address that. So we hypothesized that it would be associated with reduced severity of disease. That benefit would be stronger in women. In the diabetes prevention program, metformin reduced CRP more in women than men. And I think that, anti-inflammatory effect would be one of the main ways it might convey benefits. And then we also thought, we would see this in laboratory results and that there would be no increased risk of acidosis on presentation to the hospital in people who had been on metformin versus those who had not. So this is just an overview of our design. I'll try to watch the time so I don't take too long, but T0 would be time of SARS-CoV-2 positive diagnosis, adults age 30 to 85 with at least one outpatient healthcare encounter in the year before their positive COVID test. And then we later made, initially we were only going to do hospital or length of stay, death, and intubation as the outcome, but we later made hospitalization one of the primary outcomes. So this is just an overview of exclusion criteria. This was limited to people with type 2 diabetes, not prediabetes, gestational diabetes type 1, or PCOS. So we actually I started working with others on this in September, but we then quickly just started working on BMI, because early on, that was a big part of the analysis that I wanted to do, was to be able to control for BMI. And then even after, a lot of work defining BMI, we found that it was missing at a number of sites, and appeared to be not missing at random, because some sites just had a very high amount of missingness around BMI. So we did exclude those sites that had over 90% missing of height or weight. But I guess an update as of today, a lot of that missingness has been improved, which is great. And then this was initially one of our secondary analyses for the first paper, was to do this in people without diabetes. Metformin is used for PCOS, for weight management, but that became, I think it would have confused the paper, because then one of the main aspects of the first paper is this active comparator cohort comparison in people with type 2 diabetes. So we've made this a second paper, and that's what Lauren will present. And then how do we define diabetes? This is just an overview. So we looked at how Cornet has defined it before. And, we worked closely with experts like John Buse, and we, had a sensitive definition, just one of these criteria to be the sensitive definition of diabetes. And then a specific one, you had to have two of those criteria. So for the metformin paper, we said you did have to have an ICD, so a specific definition of diabetes, an A1C or an ICD code, and then by definition, a medication prescription as well. And then this is just an overview of the analytic approach. And there, Jared is on the call right now. He can answer more in-depth questions if you have questions about the analysis, but we are using inverse propensity weighting and a multiple imputation. And this is just an overview of the missingness: 1% for age, 3 to 5% for height, weight, BMI, after excluding those sites. And then we did control for creatinine and GFR in those for whom we had it available. So this is our table 1, and sorry, I haven't had a chance to put it in a different format than this, but as you can see, we have 2,100 people in the metformin group, 150 in the DPP4 group, and 400 in the sulfonylurea group. The metformin group is the youngest, but they have the highest BMI on average. And then you can see the prevalence of other chronic disease here. And then I'll get down to our results. Any questions so far? I'll just keep going and then answer questions at the end. So this is the weighting of the variables. The pink is before the weighting and the green is after. So you can see after the weighting, everything was well below 0.1 for the balance of the variables in both the metformin versus DPP4 comparison and metformin versus sulfonylurea comparison. And then this is this is just what I threw together as sort of a visual overview of the results. So these are risk ratios. This is 1, and then 95% confidence intervals. Unadjusted results here for whether or not someone was hospitalized compared to DPP-4 inhibitors or sulfonylureas, and then ventilated, which means intubation, or ECMO. Those two were collapsed together or deceased. And then this is the adjusted results. And then we have a few of we had some pre-specified subgroup analyses that we wanted to do, and I have those results also. So after adjusting for A1C, this is brand new data, but you can see the adjusted results. So, nothing was significant, but trending towards a reduced likelihood of being ventilated or of mortality. And then, not excluding those who did not have an A1C, kind of similar picture here, but nothing reached a level of significance after adjusting for level of A1C. And then looking at the pre-specified subgroup analyses by gender, you can see some potentially higher benefit in women, but also significant benefit in men as well for reduced likelihood of being ventilated. And this, sorry, that was the same thing, except I made the font bigger here. And then this is a paper that just came out in the past week or two, and they looked at whether or not prescription for metformin reduced the likelihood of getting COVID-19, and I think and dying. But given those antiviral hypotheses, this is an interesting question to look at. And you can see the accrued and adjusted outcomes here. So nothing statistically significant, but maybe a trend towards benefit there. And this is the negative control outcome. And those are just the numbers. I think that is it. Thank you. I think I left enough time then for Lauren to present results on looking at whether or not metformin reduces severity of disease in people who do not have diabetes.
Great. I'll just share my screen real quickly here. So hopefully you see some slides now. So as Carolyn kind of alluded to, a sort of branch off or secondary analysis from the primary paper that will now not necessarily be included in that paper, but will hopefully be a second manuscript, is looking at exploring the associations of metformin usage within individuals with prediabetes and polycystic ovary syndrome, or PCOS. There we go. So as was kind of discussed already, there's some potential for metformin to be beneficial for individuals with diabetes as opposed to other monotherapies, and metformin seems to be improving outcomes. So then this leads to the next question of, is this only happening in individuals with diabetes, or do individuals without diabetes experience these same beneficial outcomes when they're utilizing metformin? And so the populations of interest for us included individuals with prediabetes as well as those with polycystic ovary syndrome, or PCOS, as they can be prescribed metformin as an off-label use. So the primary outcomes that we were looking at for this investigation were focused on the odds ratios of the population of interest, so PCOS or prediabetes, moving either up or down a category of COVID-19 severity. And the categories that we are looking at are the ones that were documented in the clinical characterization and early severity prediction paper that was put out for N3C in January, I believe. And so those are the 5 categories of that clinical progression scale that was put out by WHO. So if you're not familiar with those, that includes mild, mild ED, moderate, severe, and mortality hospice. And you can see all of those in that complete patient table with derived scores in Enclave. So just to give you a little bit of background as to how we categorize our patients, we used a combination of concept sets that we developed as part of our research group, as well as using some already developed from other groups using the Enclave. And then we also evaluated patient labs, particularly hemoglobin A1C, to try and classify these clusters of individuals. So COVID-19 positive individuals were those who had an encounter with a healthcare provider after January 1, 2020, that they had a positive SARS-CoV-2 lab test. For individuals with diabetes, we developed concept sets that included type 1, type 2, gestational, or any other diagnostic condition that was characterized by an abnormal blood glucose. And we also counted individuals as having diabetes if they had a hemoglobin A1C that was over 6.5%, which is American Diabetes Association range. We also looked at individuals with prediabetes. Those individuals, same thing, made a concept set, identified those with concepts for prediabetes, and then classified those with an A1C that was between 5.7 to 6.4%, which is again the recommended range for prediabetes. And finally, for the PCOS individuals, we were only able to utilize concept sets and concept codes to classify those patients. So first we looked at individuals with prediabetes. So we started off with our cluster of individuals who had COVID-19 and showed up as COVID-19 positive. To make sure that we eliminated all the individuals with diabetes from our analysis, we first off just removed all of those patients. And then from the remaining patients, we identified individuals who had either that diagnosis of prediabetes or who had the A1C within the realm of prediabetes to get that cluster of patients with prediabetes. And from that group, we then utilized drug eras to try and assess whether or not they were on metformin. So that led us to get individuals were considered treated with metformin if they had a drug era for metformin prior to all the way up until the day of their diagnosis with COVID. So that gave us a treated group and a non-treated group. So between both of those groups, we utilized propensity matching to create matched pairs. They were matched on age, gender, BMI, comorbidities, and smoking status. And then from the matched pairs, we then used ordinal logistic regression to be able to assess them for the impacts of metformin on COVID severity, and again, on the likelihood of it to move up or down in terms of the severity classification. So for this assessment, we ended up getting 789 matched on metformin and off metformin pairs, but we did not remove specific sites based on BMI missingness. So they were technically included, but the patients who had any missingness of any of the covariates that we utilized were removed from the assessment. So all of the patients that were actually included in these values do have every single one of the covariates, but it did lead us to have a substantial amount of missingness and a large reduction in our N just due to the fact that we had all that missingness. So we saw about 47% missingness for BMI, which is the highest category of missingness that we experienced. So utilizing only those people that have all of the covariates available, we then were able to see that metformin does appear to be protective in individuals with prediabetes with an odds ratio of 0.7, my apologies, and a confidence interval that does not go higher than 1 and a significant p-value. So at least from kind of our initial exploration at this point, it does seem as though metformin is protective for individuals with prediabetes. So the second branch of the study was looking at individuals with PCOS. We took a very similar approach to categorize out our patients with PCOS. We again started with COVID-19 positive, removed all the patients with diabetes, and then kept only patients who had a concept code for PCOS. We did include a flagger for individuals with prediabetes that were within the subset of folks with PCOS. So again, that used the same qualifiers as before. So then we had PCOS patients with prediabetes utilized as a covariate. We again assessed whether or not they were on metformin. So we had our treated and not treated groups. We used that propensity matching again, and then utilized the ordinal logistic regression. So very similar processes here. We were able to get 252 matched pairs for on metformin or off metformin. Again, same issue here with BMI missingness. But we had some differing results for the PCOS patients. We actually did not see any effects of metformin within this population. So the odds ratio very close to 1 here, confidence interval crossing 1, and not a significant p-value. We also didn't see prediabetes having any impact on whether or not someone would increase or decrease in their COVID-19 severity. So yes, it does not appear, for at least this initial exploratory investigation, as though metformin is beneficial for individuals with PCOS. So just some very brief conclusions. As we've kind of already heard from Carolyn's group, monotherapy metformin can be beneficial for those with diabetes, and it does seem to be beneficial for individuals with prediabetes, but we're not seeing the same impacts for individuals with PCOS. So we're hoping to kind of continue refining this investigation to explore things such as patient matching on hemoglobin A1C, imputation of missing data, particularly BMI, since it's such high levels of missingness, and including some further statistical analysis. And I would be happy to take any questions that anyone has. And I'm sure Carolyn would too.
Those are great talks. That was really fantastic stuff. Questions? I guess one question is, are there matching control groups for your patient groups from Sai Madapali?
Yes, so for our paper, we did matching between people on not on metformin, but on another diabetes monotherapy. That's, I should say, oral monotherapy, so not insulin or an injectable medication.
Great. And Ken Gersig says it nice, really nice work, Dr. Bramante. Other questions? Okay. I'm curious how metformin work could inform DADOS and what we are doing.
I don't know what
Ken
data,
Gersig.
but I'm happy to help or send whatever data I have.
Great. Okay. Any other questions? Okay. Well, thanks everybody. I think this is a great session, and I appreciate all of the interesting work. So take care, and we'll see you folks soon. Thanks.
I'm glad no one asked me an informatics data question.
No, that's great. That's great work. No, this is really just the sort of thing that N3C is designed to do. That's fantastic.
Yeah, no, I've learned so much. No, it's been great. And Lauren and her team have been so wonderful and fast. It's been great to work with them too.
Mm-hmm. Yeah, no, I mean, having really great scientists and people with domain and biomedical knowledge, as well as in working with people with informatics knowledge, that's really what we're trying to do.
Yeah, that's great.
Okay, we'll give people 4 minutes back, and thanks for coming. Bye-bye.
Thanks so much.